Colleen is wondering, can medical marijuana be helpful acutely for migraines when you've already used up your 3 days of other rescue medications?
Well, a couple thoughts about that. First of all, as most of you probably know, marijuana is an illegal substance in this country. So I don't know if I can legally recommend anybody take marijuana. Having said that, many people are probably also aware that there's a lot of evidence that suggests that marijuana can be beneficial for glaucoma, significant nausea and vomiting, especially in cancer sufferers. And there is some small evidence that suggests it can actually be beneficial to migraine sufferers as well. This is my own personal opinion. Take it for whatever it's worth, but I do believe that we should be able to study marijuana so we can answer some of these questions. The real problem here is we don't have answers. Does this help or does this not help? Let's, in some ways, in a controlled fashion with a lot of monitoring so we can make sure that no laws are broken or this type of thing. But we can set that up. We can study it in various illnesses and see if it actually helps people. And if it does help people, then an argument can be made we should use it in the select individuals who can benefit from it. At least that's an argument I would make. We have many mind-altering drugs, morphine, for example. We have many prescription medications that are mind-altering, and we use them every day in thousands, if not millions, of people. Marijuana is also a mind-altering drug, but again, I would argue we should study it, see if it has any beneficial effects, and if it does, use it in that patient. So as far as recommending it for this patient, it's kind of tough to recommend it simply because I don't have a lot of data, and I don't have an official recommendation. And as I mentioned, it's illegal. So that's a huge barrier to overcome. So more than anything, perhaps this patient should write their congressman and try to get some laws changed so we can study this and find out actually who could be a benefit to people. Go ahead,
I have a question from Holly. I suffer from complex or complicated migraines, and my left face will droop with these types of migraines. Thus, I cannot take some of the triptans. What types of medications can I speak with my doctor about?
Well, yeah, the triptans, she may have, I don't know this patient's history, but based on the little bit you described there, she may have what we call hemiplegic migraine, or she may have basilar migraine. So yeah, the triptans are medications she should probably stay away from. Dihydroergotamine is another medication she should stay away from. The type of medications that she could use, there are several. Anti-inflammatory medications are probably her first option, or arguably her first option. Those are available in pills as well as shots. She can use medication, for example, called droperidol. There are several studies about droperidol for migraine, and that would be an option for her. She could use corticosteroids, are another medication that we could potentially use in her. There are other medications, there's less evidence of efficacy that they work, but given that she has a pre-existing condition, that's when we start going to these types of medications. Depacon, I can tell you where I work. We use Depacon, which is the injectable formulation of Depakote. That may be an option for her. Another medication such as Keppra, which is, Keppra comes as a pill as well as an injection. IV Depacon might be, or I'm sorry, IV Keppra may be an option for her. And that's just to name, 3 or 4 right off the top of my head. There's probably 3 or 4 more that she could also use as well. Obviously, she needs to work that out with her physician. She's got a pre-existing condition. She may have some other pre-existing conditions, or she may be on other medications that could interact. So she needs to work that out with her doctor. But there's a couple right off the top of my head. Anti-inflammatories are the first thing that come to my mind. Go ahead, Zach.
Well, Elavil worked good for Colleen, but it caused her to have severe dry eyes. Is there anything she can do about that?
Yeah, dry eyes. Those types of medications, Elavil belongs to the TCA family. You had mentioned mipramine a few minutes ago. Elavil, amitriptyline is the generic name, belongs to the TCA. The TCAs can cause what we call SLUD, S-L-U-D. SLUD stands for salivation, lacrimation, urination, and defecation. So they can dry out your mouth, dry out your eyes, cause urinary retention, and cause constipation. So I'm not surprised to hear her have that side effect. Couple of options here. Number one, reducing the dose may be an option for her. That's usually the first thing we go to. And you said she had dry mouth, correct?
I'm sorry, what was that?
Her side effect was dry mouth or dry eyes?
Dry eyes.
Yeah, dry eyes. Another option, a simple option for her, is to use some type of watering eye drop, artificial tears. She can buy that at her local pharmacy without a prescription. She can put that in her eyes a couple of days. That's often what we do at the headache unit where I work, and many patients say that's beneficial to them. So lowering the dose is an option. Artificial tears is an option. If things are really bad, there's actually some medications we can give that promote secretions. Bethanocol is one of those medications, and one we often use. We don't typically use it for dry eyes, but we'll use it for patients who have really bad urinary retention or really bad constipation. But that could be an option for her as well, an oral medication. The only problem with that is you're taking drug A to counteract the side effects of drug B, and sometimes that may not be the best way to go. So the simplest things for her to do is first reduce her dose and/or use the lubricating eye drops. If that's not enough, then either talk to her doctor about getting a secretion-promoting medication, or just switching to a completely different medication altogether, stopping the Elavil outright and moving on to something else.
Well,
go ahead, Jack.
Jamie asks, I'm extremely careful not to use my meds more than prescribed, but I find myself worried that I might have a lower threshold to falling into medication overuse cycle. Is there a way to differentiate between rebound headaches and non-rebound headaches?
Well, by definition, actually, the International Headache Society did not define rebound headache. They have medication overuse headache. And by definition, first of all, you have to be using a substance. Depending on the substance, they have different quantities that you have to be taking. But as a general rule, it's 3 or more days per week of that acute agent. And then you have to be taking it for a defined period. And then they had for many years, you had to take that agent away, and your headache has to get better within 3 months. Well, the real world problem with that is we take the agent away. First of all, we got to wait 3 months. The other problem was during that time, most people are doing other things, for example, starting preventive drugs. So it's difficult to say whether it was stopping the drug or starting the new drugs that made the patient better. So essentially what she's asking is, again, where's the dividing line between too much and too little? And the reality is we just don't know yet. So it's a big question that we need to get answered, but we just don't know yet. And as I said, it's probably different for every single patient. So we just give general guidelines, no more than 3 days per week. And when you exceed those, please seek out help. So I believe I answered the question.
Yes. Jan asks, there are several Triptan medications on the market. Are there significant differences among them? Is one better than another as an abortive medication for migraine, or is it just what works for each individual?
It's just what works for each individual. You know, the Triptan medications, Imitrex was the first one, came on to the market in the early 1990s. And during the late 1990s and most of the 2000s, there were a lot of studies, there was a lot of research, a lot of energy, and a lot of money put into trying to find the best Triptan. And now, 15 or 20 years later, after all that time, energy, money, and effort, what we know is the best Triptan is the Triptan that works for that patient. So yeah, it's really a trial and error process. It depends on the person. It may take trying 2 or 3 different things. That's one thing I want to point out. If one Triptan does not work, you can still use a different Triptan, and that Triptan may work very well for you. Some of the ways to separate the Triptans are probably, first of all, by formulation. I mentioned a moment ago, Imitrex comes as an injectable. It's the only injectable. For someone who has significant nausea and vomiting, or if their headaches come on rapidly, just within an hour or two, well, then an injection is probably appropriate for that patient. Zomig and Imitrex come in a nasal spray. Again, if somebody's got a lot of nausea and vomiting, or the headache comes on really fast, then they should probably go with a nasal spray. Zomig and Naxalt come in a meltable tablet. Some patients like the meltable tablet. They find they tolerate it better, particularly, again, if they have nausea and vomiting. Sometimes it just boils down to which one your insurance company will pay for. That's often the best one to go with first. Back 15 years ago, the Triptans were relatively pricey medications. Over the last decade, the prices of all of them have come down. Sumatriptan is now, or Imitrex, which is Sumatriptan, is now available as a generic. I wouldn't be surprised if in the next year or two we see some other generic Triptans come to the market. Probably Zomatriptan will be one of them, although to my knowledge it's not here yet. But sometimes cost is the best way to separate the Triptan as well. So really you just got to look at your patient. What can they afford, or what does their insurance company pay for? Do they need something non-oral to use? And then if not, then just try any of the oral triptan. I tell patients, treat a minimum of 3 attacks. Some headache specialists say treat a minimum of 5 attacks. But treat 3 attacks. If your triptan fails, it doesn't help you for 2 out of 3 attacks, or if it doesn't help you for 3 out of 5 attacks. In other words, it's failing the majority of the time. It's failing the majority of the time. It's time to make a switch. It's time to go back to your doctor and let your doctor know this, and it's time to try something else. Unfortunately, I often see one of 2 situations. People who only try a drug one time, a triptan, one time, it doesn't work, and they give up on it. That may not be the best way to go. You got to try it a couple of times. The other situation we see is people who have been on a drug for many months, if not many years. They've used it dozens of times. It's never worked for them, and they're still on it. That obviously is not a good situation as well, and they needed to be switched as well. So bottom line is, yeah, as is the case with a lot of illnesses, we need to tailor the therapy to the patient's needs and the patient's responses. Go ahead, Zach.
Raymond asks, injectable Toradol is one of my main NSAID migraine abortives. As you know, this medication has been in a national short supply for some time. Do you have any sense about why this shortage exists or how much longer it will be in effect?
Well, just drug shortages in general, if any of you follow the news, you've probably seen that it's a huge problem in this country right now, and it's not limited to headache drugs. There's a variety of medications that are unavailable. In fact, there has been congressional hearings about this, and actually just recently President Obama has signed some legislation that changes some of the requirements for drug companies in terms of letting people know, letting clinicians and patients know beforehand that they're going to run out of a drug. Right now, drug companies are not required to alert anybody that they're going to run out. They can just simply announce one day, we don't have it anymore. The reasons why these various drugs are not available, there's a bunch of different reasons, and there's actually some controversy surrounding the reasons. Sometimes it's the raw material is unavailable. Sometimes the factories where these medications are manufactured have to be approved by the FDA, and there can be manufacturing problems. The FDA may not approve the facility because there's some type of problem. There have been some people that complain the FDA does not have enough inspectors and they need to do these inspections more quickly. There are some companies who simply aren't making much money or making any money on the drug, and they simply decide not to manufacture it anymore. Now, we can have a debate about whether that's a moral or an ethical thing to do, but the reality is, as it stands right now in this country, it is the legal thing for them to do. So the reasons for drug shortages are varied. It's affecting a lot of people. It's affecting, for example, some cancer medications. Sadly, there have been some people who have died because they had lack of access to certain cancer medications. There's been talk about importing some of these medications from foreign countries. So on and on. It's a huge problem affecting millions of people in this country, and I don't foresee the problem being solved anytime soon. In terms of Toradol, I'm not aware that it's on back order. At least Toradol is the brand name. Ketorolac is the generic name. I can tell you at the hospital where I work, we have Ketorolac injection. We do use quite a bit of it, and I'm not aware that we've had any supply problems. So I wonder if this patient is looking for brand name Toradol, maybe perhaps they could try get the generic Ketorolac, or otherwise, yeah, they're going to have to talk with their local pharmacy. It may not be a manufacturing problem. Sometimes it's a problem with the distributor. The local pharmacy gets their meds from some big warehouse in the area. If that warehouse has whatever problem, I don't know, their truck broke down or various problems that can occur, this might be a local problem. But I can tell you where I work, we have Ketorolac. We do use it, and we haven't had any problems obtaining it, at least to my knowledge. So anyway, go ahead, Zach.
Good. My daughter has been prescribed 700 milligrams of Topamax per day. That's 300 in the morning and 400 in the afternoon. And then her headache symptoms include nausea, constipation, and diarrhea. What are your thoughts on this dose? Could this high of a dose of Topamax be the culprit of her GI problems and not the headaches themselves?
When I was in pharmacy school and you took a test, you could always put nausea and vomiting down as a side effect for any drug and get the question right. So certainly any medication can upset your stomach. Some are more likely than others, but any medication can do that. I talked about Topamax a few minutes ago, and I said, at least in terms of treating headache, the studies, the highest dose that they were looking at were 200 milligrams a day. I'm not aware if we had, I think once we had somebody on as high as 700 milligrams. So it's two things. It's a very high dose, and it's a dose we do not typically use for the prevention of migraine. So two things about that. Yeah, it's a high dose. They may want to reevaluate that because arguably it isn't helping her, and then definitely it could be causing some of the symptoms that she's reporting. Usually when we get in high dose of Topamax, most people complain of what we call cognitive things. In short-term memory problems. They can't remember where they put their car keys down. They walk into a room and they don't remember why they came into the room. Those are the problems I hear most often with Topamax. Those are not the problems this patient's describing. So yeah, her upset stomach could be from all that Topamax. That's something she'll have to talk out more with her doctor. Go ahead, Zach.
Anne asks, occasionally I'll get a migraine that my triptans won't stop, and I'll take a Vicodin, and it helps a lot. Why won't my neurologist prescribe Vicodin or similar drugs for migraine relief?
Well, a couple thoughts about that. First of all, there are no studies that show Vicodin works for any kind of headache. So that's problem number one. The other thing, medications like Vicodin, which contains hydrocodone, which is a narcotic, those are the most common, or one of the most common causes we see of people developing rebound headache or medication overuse headache. Actually, how she's using it right now is the correct way to do that. Her initial choice is a Triptan, a migraine-specific medication, in this instance, Imitrex. The advantage of Imitrex versus something like Vicodin is Imitrex can help the migraine go away and help you get back to your life. What I mean by that is it helps improve your ability to function. And that's what most people want. They want to get back to work. They want to get back to their kids. They want to get back to doing their daily things. Medications such as Vicodin, which for the majority of people make them drowsy, not only does it improve your ability to function, it actually decreases your ability to function by making you drowsy. So often what we do is we tell people use a medication like Imitrex first because our initial goal is to get you back to your life. Now, if you take your Imitrex and 3, 4, 5, 6 hours later it hasn't helped or hasn't done anything, then our goal changes. Our goal is now pain reduction. We're trying to reduce your suffering. To do that, a medication such as Vicodin is appropriate. The problem with that, though, is so many people, they take a Vicodin and then they lay down, or they're drowsy, or they got to go home from work, or whatever it is. They're not functioning as well, and that's the downside to those types of medications. So the way she's using it right now is actually a good way, in a way I wish more people would use it. The sad reality is there's far too many people who take their Vicodin first and their Imitrex last, and they often don't even get to their Imitrex. Their use of Vicodin skyrockets, their frequency of headache skyrockets, and then they end up in the headache unit where I work. So the bottom line is her neurologist is not prescribing more Vicodin because they're concerned about developing a rebound headache, number one, and number two, it's not shown to be effective for migraine. Go ahead, Zach.
Do you know of any prescription medications for tension headaches? Crystal actually has major ones.
When I hear somebody saying they have major tension headache, I often wonder if they in reality have migraine headache. Up to a third of people who have headaches that fulfill migraine criteria are misdiagnosed as having tension headache. Tension headache, by definition, is not exacerbated or made worse by daily activity, by doing work, by cooking dinner for your family, or just doing the things of daily living. Whereas migraine headache is. That's, in my opinion, the key difference between tension headache and migraine headache. Most people with tension headache can either just ignore it, maybe take a Tylenol and just go about their day, whereas people who have migraine attack, they have to lay down, their ability to function is significantly decreased. So when I hear somebody says, I get these major tension headaches, I often wonder if they're misdiagnosed migraine sufferers. Otherwise, in terms of prescription drugs for tension headache, particularly episodic tension headache, I'm not aware of any because I don't see those kind of patients. They don't end up in my clinic. Tension, like I said, most tension headache sufferers either do nothing or they simply take some type of over-the-counter product and treat it themselves without any problem. We do sometimes see people with chronic tension headache. In other words, they have a headache more than 15 days per month. And there are prescription medications we give to those patients. both for the acute treatment as well as the prevention of their headache. There's a variety of different things. I'm not going to ramble off a bunch right now because, again, it depends on the patient, what other illnesses they have, what other medications they have. But a lot of those medications are medications we also use for chronic migraine. So,
I actually have two people who are asking about preventative daily medications causing daily headaches. Are you familiar with this phenomenon?
Well, preventive medications, by definition, trying to prevent your headache. No, it's definitely, the evidence is pretty clear. The acute medications are the culprits in making, propagating this rebound headache cycle, or this medication overuse cycle. I'm not aware, I'm trying to think of any studies that say preventive medications can actually make your headache worse. And it's often difficult to determine if someone's headache is getting worse and becoming more frequent and more severe. What's causing that? Is it the medication they're taking? Is it something else they're taking? People drink water every day. So is it the water that you're drinking every day? It's tough to prove causality. Simply because you do this or do that, that doesn't prove this is what's making your situation worse. So it's tough to show that. What we do know is people overusing acute medications do not get better until they stop those acute medications, or the majority of people do not get better until they stop that. I'm not aware of anything that suggests that preventive medications make your daily headache worse. But again, if you think that's your situation, or if you think that's occurring, talk to your doctor. Let your doctor know that. We have numerous preventive medications we can select from. If you think drug A is a problem, talk to your doctor. We can try drug B and see if that improves the situation. Go ahead, Beck.
If you suspect that you have rebound headaches, is cold turkey the best response, or is there a better way to go about dealing with rebound headaches?
Well, it depends on a couple of things. Some medications, like the Fiorinol somebody mentioned a few minutes ago, stopping that cold turkey is a bad idea because that puts you at increased risk for seizures. So first of all, we have to find out what medication are you overusing. If you're using, for example, an anti-inflammatory, or which medication you're overusing. If, for example, you're overusing an anti-inflammatory medication, that is a medication you can stop cold turkey. If you're overusing a Triptan, that is a medication you can stop cold turkey. Fiorinol, butalbital products, as I just said, you should not. Narcotics are often medications we don't want to stop cold turkey because you can end up with withdrawal symptoms as well, and many people find that unpleasant. That's something I see every day at the headache units where I work. So first of all, if you can stop cold turkey, it depends on what drug you're taking. Then it often depends on the person themselves. When you stop the acute medication that you're overusing, your headache in all likelihood is going to get worse before it gets better. That's the problem with rebound headaches. So some patients, they're very determined, highly motivated. They say, I want to get through this. I'm just going to do a cold turkey, and that's that. Whereas other patients say, no, I want to be as comfortable as possible. I want to take this slow in a controlled manner. I don't want to experience any sort of, worsening of my headache. So then you take it slow. So it depends on the drug, and it also depends on the person. And then sometimes it depends on your doctor and the other people who are caring for you. If they have a lot of experience in this situation and how to manage any problems that might come up, then they might be able to do it a little quicker. Whereas someone who doesn't have a lot of experience, it's probably best if they take things a little bit slower. So the answer is, it just depends.
Susan is wondering if a good way to avoid medication overuse headaches is to rotate through things like Tylenol, ibuprofen, and aspirin, but never taking any one of them more than 10 days a month. Will this help with preventing medication overuse headache?
Well, you mentioned 3 medications, and you mentioned 10 days per month for each one. 3 times 10 is 30. So that works out to basically 1 medication a day. And I can tell you where I work, we've seen a number of people who've tried that, and it has been unsuccessful. Yeah, we get people who want to take drug A on Monday and Tuesday, and take drug B on Wednesday, Thursday, Friday, and take drug C on the weekend, and it just doesn't work out. No, the reality is if you exceed 3 days per week combined for all your acute medications, you're at increased risk of developing rebound headache, medication overuse headache. If you find you need an abortive medication every day, you need to see your physician, because we need to come up with a better plan. It's obviously not working for you. You need something every day. We need to try to get you to a situation where you only need an acute medication a couple of days a week. What really you need is better prevention, both drug and non-drug prevention, and that can take a while to sort all that out. But yeah, the bottom line is taking any abortive every day. In my experience, it just doesn't work for people. Go ahead, Zach.
I have a person asking about whether intravenous medications are more effective or if they're beneficial for migraine, or if there are specific intravenous medications for migraine.
Well, a couple things. Intravenous would be a medication we would only give in a hospital, because most people don't have the skill to put a medication in their vein at home. So I think what the patient's talking about is an injection, such as an intramuscular injection, which goes into your muscle, or a subcutaneous injection, which just goes underneath your skin. People certainly can do that at home, and we have many people who go home with intramuscular and subcutaneous shots. The reality is, yes, those shots can be very effective for migraine. The advantage of a shot versus the advantage of a pill is a shot starts to work faster, and for many people that's very important. A shot also bypasses your stomach. Migraine is an illness that's one of the diagnostic criteria is nausea and vomiting. A lot of people have nausea and vomiting with their migraine. So with a shot, we can avoid the stomach, so that's an improvement as well. But the biggest advantage of a shot is it starts to work quicker. The disadvantages to a shot, number one, you have to give yourself a shot, so you have to know how to do that. You have to poke yourself with a needle, although there are now some devices, needle-free devices. I say needle-free, not pain-free. Some people have mistakenly thought that if it's needle-free, they will not feel any discomfort, and that hasn't been the case. You still might feel some discomfort. You're just not poking yourself with a needle. But the disadvantage is you got to give yourself a shot. Then the other disadvantage is, as a general rule, injectable medicines have more side effects than oral medications. Again, that may or may not be the case for a particular patient, but as a general rule, that's true. But yes, we definitely send people where I work home on lots of injectable medications, and many of those patients are quite happy with that. In many instances, what that allows them to do is avoid a trip to the emergency room, which, you go to the ER a lot of times, they're going to give you a shot of something. So you can take that shot of whatever it is at home and avoid a trip to the ER. And many patients find that beneficial for a variety of reasons, not the least of which is you don't incur the cost. And then in the emergency room, there's often a lot of bright lights and sounds and things that can really be disturbing to migraine sufferers. So if you can avoid that, stay at home where it's quiet and it's dark, that's a better way to go. So anyway, go ahead, Zach.
I have someone asking whether the chemicals in hair dye could possibly cause headaches. Have you ever heard of something like that?
I personally have not. I mean, I've had numerous patients over the years come in and implicate various chemicals from various things, from paints, dyes, or whatever. What I encourage patients to do is keep a headache diary. Headache diaries are the best way to identify patient-specific factors that might be affecting their headaches. You can get on the internet and you can download lists of 107 different things that you should stay away from. The reality is 106 of those things probably are not going to bother you at all. The best way to identify specific factors affecting your headache is via a diary. When you get an attack, write down what you were doing, what the situation was, what you may have been exposed to, what medications you took to treat your headache. Keep that information and keep it for at least a month or two, ideally even longer, because there are situations where you can see, say for example, you got your hair dyed. I don't know how often she's getting her hair dyed. I'm just going to guess maybe it's once a month. But if they can show that every month they get their hair dyed and then their headaches gets worse, and next month was the same thing, and next month the same thing, now we've got some information that strongly suggests that this hair dye is a problem for this particular patient. So that would be a better way to go. But I personally have not heard of hair dyes causing migraine in patients.
Okay.
Go ahead, Zach.
I have a question from Irene. I'm probably going to botch this medication, but a new neurologist recently prescribed me methylprednisolone and nortriptyline. The daily headache was unbearable, so I stopped and went back to clonazepam and Lexapro. He also prescribed Triptan with 0.5 milligrams, but I'm terrified to take it. Any thoughts? Also, what do you think works best as a preventative?
All right, we have about 4 questions there. Can you read the first 2 questions or first 2 medications again?
Yeah, it's methylprednisolone and nortriptyline.
Okay, just one moment. Yeah, methylprednisolone is a steroid. I mentioned those a few minutes ago. Those are medications we use acutely for migraine attacks. Sometimes we usually only use them on a short-term basis, maybe a couple of days or a week or 2. Those medications work by a couple of ways. Their primary action is reducing inflammation. And then nortriptyline, that is a preventive medication. That is a medication that raises your serotonin and norepinephrine levels. So that is a medication that I said you take preventively, you take every day. The thing about preventive is, I haven't mentioned this previously, but preventive medications usually take at least 3, 4, 5, 6 weeks to really start working, whereas her methylprednisolone is something we're looking to, have some benefit today. So she'd have to wait a couple of weeks with her nortriptyline to get some effects. And then what were the next 2 medications?
That's Lexapro and clonazepam combined with niratriptan.
Okay. So the Lexapro is also a medication that increases your serotonin levels. Generally speaking, we do not give medications like Lexapro along with medications like nortriptyline. So I suspect, or I would hope that the nortriptyline was stopped before she started the Lexapro. But those medications do similar things. They raise your serotonin levels. Clonazepam is a medication that belongs to the family called the benzodiazepines. Benzodiazepines can be used for a variety of different things. They can be used for anxiety. They can be used for seizure. They can be used for sleep, restless leg, just to name a few things. Generally speaking, we do not use a lot of them for headache. So there's not a lot of data to support their use for headache, and we tend to stay away from them, assuming the patient does not have anxiety or restless leg or seizures. If they have a pre-existing condition, then we might use something like clonazepam. And then you mentioned, I think, Neurontin was the 3rd one. Is that correct, Zach?
No, that was actually niratriptan.
Oh, I'm sorry, niratriptan. Niratriptan belongs to the triptan family. It's like Imitrex. It comes, you said 0.5, but actually I think what they meant is 2.5 milligrams. That's a triptan. That's an acute medication. That's for short-term use when you have an attack. So, and then what was the last medication? Did I get them all?
Yeah, that would be it. It was clonazepam, Lexapro, and niratriptan.
And repeat her question one last time, please.
Sure, 1 second. The question was, a new neurologist recently prescribed me methylprednisolone and nortriptyline. Yeah. The daily headache was unbearable, so I stopped and went back to clonazepam and Lexapro. He also prescribed niratriptan at 2.5 milligrams, but I am terrified to take it. Any thoughts, and what do you think works as best preventative?
Well, the other thing is she's terrified to take it. Did you tell your doctor that? It's it's always an unfortunate and somewhat sad situation when I see that patients get prescribed a medicine by their physician, and then for various reasons they don't want to use it. They're scared to use it. They cannot afford to use it, or what have you. People have different reasons they don't want to use a medication, but they didn't tell their doctor that. When your physician prescribes a medication, they're going on the assumption that you're going to take the medication as prescribed. If you are not doing that, that's okay, but let your doctor know that, so we can try to come up with some type of alternative plan that is acceptable to both of you. If you're terrified of taking a medicine, that's just, that sort of in some ways breaks my heart a little bit. I don't want patients in that kind of situation. The other thing I don't know is, why is she terrified? Is this something where just simply some more drug information about side effects of the drug may help, relieve this patient's fears, and then she would be willing to take the niratriptan. And then she apparently was on the clonazepam and going back to that, but I just wonder, was it working initially? Because she changed to the methylprednisolone and nortriptyline. Well, she must have changed for a reason. It must have been that the medications she was on were not working. So if you go back to them, then the chances are pretty good they're not going to work again. So bottom line here is I think this is a patient who needs to have a good heart-to-heart talk with her doctor. Go ahead, Zach.
That's actually all the time we have tonight, so we really appreciate you coming in and answering these questions, Dr. Wenzel. And be sure to join us, everyone. We'll be having our next chat on July 26th at 6:30 p.m. Our guest will be Dr. Benjamin Friedman, and he will be addressing questions regarding the management of your headache in the emergency department. Thank you once again for joining us.